So tonight's presentation, Optimizing Bone Health in Patients with Prostate Cancer. It's with great pleasure that I welcome back Lori Styner, registered nurse and bone health specialist at the Prostate Cancer Center. And with her tonight is Dr. Mariko Shibata, bone health consultant at the Prostate Cancer Center. I'm sure you've all read their biographies in the October edition of the Digital Examiner. But what can you learn from the internet? Let me tell you. For example, Lori has a Bachelor of Nursing degree and has over 30 years experience working in clinical research. She's been at the Prostate Cancer Center since 2014 and since 2018 has been the driving force of the bone health program. In fact, it was in July 2018 when Lori last presented to our group. I'm looking forward to hearing of new developments in the program and what she's working on now. Dr. Shibata was born and raised in Calgary, and after completing her medical school and family medicine residency at the University of Alberta, Dr. Shibata started a family practice in Edmonton. But after a few years, she decided to close the practice and move back to Calgary. Dr. Shibata is now one of the team of doctors at the Britannia Medical Clinic and is the proud mother of two amazing children. When not working and spending her time with her family, she enjoys music, dance, and all things art. Edmonton's loss is certainly Calgary's gain. So without further accolation, I'm going to turn it over to Lori, and she will start us off on an education piece about bone health.
I'm Lori Styner, and I'm the bone health specialist at the Prostate Cancer Center. And this evening, Dr. Mariko Shibata and I will be presenting our very enthusiastic presentation on optimizing bone health in patients with prostate cancer. So dealing with prostate, or I'll just back up here. So our presentation is geared towards the patient, okay? So it's not meant to be any medical advice to healthcare providers, but really focused to the patient. So dealing with prostate cancer, its treatments, diagnostic tests, medical appointments can be overwhelming. In this presentation, we're going to give you something else to think about: bone health. Now, this might be even more overwhelming. However, what I'd like to say is that with what we've done with our program in optimizing bone health, we've really simplified things to make it such that it doesn't take a lot of extra time, commitment, medical appointments, anything like that to improve your bone health. Okay, so let's take a look at the agenda. Next slide. So today we're going to talk about what makes up healthy bones, a little bit about fragility fractures, what are they, and why we want to prevent them from happening. Bone mineral density testing, we're going to talk about how it's done, what the results are, and how we would interpret those results. We're going to look at factors that contribute to bone loss, and we will provide you with tips to keep your bones strong. Then I'll be turning it over to Dr. Shibata, who will talk about osteoporosis and low bone mass. And low bone mass was formerly referred to as osteopenia, but the new term is low bone mass. Dr. Shibata will talk about some of the tools used to assess your risk for fractures. And we'll talk about specifically prostate cancer and bone health, clinical practice guidelines, and then skeletal related events, what they are, what the treatment is. And then we'll finish with a question and answer period. Okay, so just a little bit about bones. When we think about bones, most people think of them as in terms of a hard material, but bones are actually living tissue and that are made up of cells that have their own blood supply. So I'm going to talk to you about a few key types of cells within your bones. So we've got two main types of bone cells, our osteoclasts, which break down old bone, and our osteoblasts, which lay down new bone. And it's really important that these two types of cells work together to develop strong and healthy bones. So we need a balance between bone that's being broken down and new bone that's being laid down to end up with strong, healthy bones. So if things get out of balance, we end up with bone loss. And this occurs when more bone is broken down than is repaired. And interestingly, peak bone mass occurs between the ages of 18 and 25. So at around age 25, that's as strong as your bones are going to be. And as we age, more bone is broken down. So it's really important that we do everything we can to keep our bones as strong as possible, knowing that as we get older, they're just with age, they're going to break down. Okay. The reason we're concerned with low bone mass is that if our bones are weaker, we're at increased risk of what's called a fragility fracture. So this type of fracture occurs from a minor accident. So an example could be just from a standing height, falling, and a patient breaking their hip. And you can see from that diagram there, that is a very osteoporotic hip bone, and you almost can see right through it. And again, a simple fall could break a bone like that. So next slide, we'll talk a little bit about different types of common sites of fragility fractures. So we see fragility fractures in spine, hip, and hand or wrist. And I'll give you an example. So my father was diagnosed with osteoporosis after he swung a golf club and broke a bone in his back. So that is considered a fragility fracture. It wasn't caused by a traumatic injury, and that was a result of low bone mass within his spine. So this is the type of fracture that we are trying to prevent by keeping our bones strong. So a bone mineral density test is a test that can determine what your bone mass is. It's also called DEXA, which stands for dual energy X-ray absorptiometry. That's a hard one to say. And it's a test that measures the density of your bones, as I've mentioned. It uses X-rays and computer technology to determine your bone mass. The test takes about 10 to 20 minutes, where you're lying still on a table and the scanner goes back and forth over the areas that need to be scanned, which are generally the hip, sometimes both hips, the spine, and sometimes the forearm. The radiation within this test is very low, and the amount of radiation that you'd receive from this test is about the same that you would receive if you were flying from Toronto to Vancouver. So some people may be concerned about the X-ray, but it's very, the radiation is very, very little. And how it works is it measures the amount of light shining through your bone. Okay, so the Osteoporosis Canada has a really good analogy on their website for how this is done. So if you think about curtains, a very thin curtain will shine a lot of light through it. And that could be compared to a bone that has very low bone mass. A very thick curtain will not allow a lot of light to shine through, and that would be compared to a very strong bone. So bone density test results, the results are measured by a T-score, and I'm not going to go into great detail about that. It's a little bit confusing. But what your T-score is indicating is how much higher or lower your bone density is compared to the bone density of a healthy 30-year-old. So if your bone density is below, you may have low bone mass or even osteoporosis. Or if it's higher than an average 30-year-old person, it would be normal. So this is just one of the assessment tools that we look at to determine a patient's risk of having a fracture. So do I need to get a bone mineral density done? So this is a good question. So the answer would be, if you are currently receiving androgen deprivation treatment, hormone treatment, then you should have had a bone mineral density test done at the time you were started on the therapy. However, that is not always the case. But at some point, it's a good idea to have one if you haven't already had one. When we started our program at the Prostate Cancer Center, we did a pilot project for about a period of a year. And interestingly enough, over 80% of the men had never had a bone mineral density test done. And of those that we got them ordered for, 70% had impaired bone mass. So they had either osteopenia or low bone mass, or osteoporosis, and never knew it because nobody ever did a bone mineral density test on them. So that's something that if you haven't had one done, it might be worth speaking to your family physician about getting one done. If you're not receiving androgen deprivation therapy, just general guidelines, and these are found on the osteoporosis website, for who should have a bone mineral density test. I won't go into great detail here, but for anybody under age 50, if you've had a fragility fracture, age 50 to 64, key points would be a fragility fracture after the age 40, a parent that has had a hip fracture, a fracture in the back, or low bone mineral density identified. If you are somebody that has a high alcohol intake, which would be 3 or more drinks a day, a low body weight, or major weight loss since age 25. And then anybody over age 65 should simply, whether men or women, should have had a bone mineral density test done. Okay. So if we can, okay. So bone mineral density testing is just one of the factors that we assess to determine the risk of having a fracture. Other factors that contribute to bone loss are low body weight. I've already talked about low bone mineral density, increased age. So the older we get, as I've already mentioned, increases the risk of our bones getting weaker. Family history of osteoporosis or hip fracture, history of a fragility fracture, history of falls, oral steroid medication like prednisone, and I've already mentioned cancer treatments such as androgen deprivation therapy. And a couple more that aren't listed on the slide would be if you're a smoker, and then I have alluded to in previous slide about high alcohol intake. So let's go to the next slide and talk a little bit about lifestyle tips to strengthen your bones. So these are things that you have control over to either maintain your bone mass or optimize your bone health. The first one there is supplement your diet with calcium and vitamin D. I've got 2 additional slides dedicated to that topic, so I'll skip over that one for now. Getting enough protein in your diet. So protein is necessary for building and repairing your bones. So it's important that you keep your bones strong with good protein intake. Do weight-bearing exercises that will help build muscle strength and balance and help prevent falls. Quit smoking. Smoking, the body absorbs less calcium if you're a smoker, and calcium is key to keeping the bones strong. Limit intake of alcohol. I've already mentioned that we don't want to see more than 2 alcoholic drinks a day. And limit your intake of caffeine. So caffeine decreases the amount of calcium that your body can use. And when we're talking about how much caffeine, just to put that in perspective, it would be maximum 2 to 3 cups of coffee a day. And limit your salt intake. So salt can decrease your bone mineral density. And the easiest way to limit your salt intake is try to stay away from processed foods. So talking about calcium, calcium is really important for keeping the bone breakdown versus the bone lay down, so the building of the bone, balanced. And 99% of the calcium in your body is stored in your bones. But if you're not getting enough calcium, your body takes from your bones and teeth and uses it elsewhere in your body. So the recommended daily intake is 1,200 milligrams, and you really want to try to get that through your diet. And there's a really easy way to figure that out. So Osteoporosis Canada has a calcium calculator I tried it today. It was incredibly easy. And you can simply, it just guides you on if you're drinking 3 glasses of milk a day, you're probably going to meet your criteria. But basically, we all start from about 300 milligrams of calcium because there's many foods that contain calcium little bits. So from there, you would look at, cheese, milk, anything that has calcium, and determine whether you're getting the 1,200 milligrams a day. If you're not, then a supplement is recommended, but we recommend that you talk to your physician about that. You're not going to get too much calcium from your diet, but you could get too much calcium through supplements. And that's why one of the really good reasons, try to get it all through your diet. Okay. The other important point to make about calcium is that you don't want to take more than 500 milligrams at a time. So not a good idea to first thing in the morning have 3 glasses of milk and think you're done for the day, because your body won't use that optimally. So you want to break that up into 3 different times during the day for your calcium intake. Vitamin D can be made in the skin from sunlight. However, we don't get enough sunlight generally in Canada to get enough vitamin D. And the other thing is we also recommend that you're not getting too much sun for obvious reasons with skin cancer, et cetera. So in the case of vitamin D, a supplement is necessary. The recommended daily dose is 800 to 2,000 international units per day. And again, your family doctor can advise you on how much you should take. You can't get enough calcium or vitamin D from foods. So again, that's why the importance of the supplement. And vitamin D helps improve muscle strength. The other thing that vitamin D does is it helps your body absorb the calcium, which we've already stressed about how important that is, given that your bones are made up of mostly calcium. So I'm going to turn it over to Dr. Shibata now, and she will finish the presentation, starting with osteoporosis and low bone mass.
Thank you, Lori. So Lori did a really good job describing, what leads to osteoporosis. Just kind of going back to that and talking about the importance of that. Osteoporosis literally means pros bone, or holes in the bone. So it causes the bones to weaken over time. And we say here quietly weakens bones because there are no real symptoms to indicate that you're developing osteoporosis. So if left untreated, it can lead to bones breaking or fracturing more easily, and we don't, without us even knowing we have the condition. A precursor for or to osteoporosis is low bone mass. And this is when the bones are weaker, but are not necessarily considered to be at a stage where they could break more easily. So we care about diagnosing and treating osteoporosis and low bone mass so that we can prevent fractures, which we know can significantly worsen quality of life, limit mobility, increase pain, and in certain cases, depending on the type of fracture, can even increase the risk of death. So we have a number of tools to help assess your risk of fracture over time. So here is a screenshot of the fracture risk assessment tool, or FRAX tool. We just have it here just to show you or give you an example of how one of the ways that we assess risk. So here you can see age, sex, body mass index calculated by the weight and height are indicated here. And then we look at a number of risk factors, and it gives us a calculation of a 10-year risk for fracture. This is another risk assessment tool referred to as the CROC system. CROC gives a 10-year absolute fracture risk based on the T-score that Lori had mentioned previously. So we look at age, gender, and fracture history and steroid use. So it incorporates less patient-specific risk factors than FRAX, but still can give an accurate picture of a patient's fracture risk. So for example, if you're looking at a 65-year-old male with a -3 T-score, that puts them in the moderate fracture risk category. But then if they've had history of a fragility fracture or a steroid, that automatically puts them in the high risk category, regardless of their T-score result on the bone density. So why do we care about osteoporosis and low bone mass in the context of prostate cancer? As Lori had mentioned previously, one of the mainstays of treatment for prostate cancer is androgen deprivation therapy, or ADT. And ADT can lead to increased bone loss, which if not appropriately treated, can lead to fractures and a worsened quality of life. Because of the detrimental effect that ADT can have on bone health, we tend to have a lower threshold for treatment for these patients when it comes to starting a bone targeting agent or an osteoporosis treatment. In fact, we find that many men on ADT may actually have a normal bone density or just low bone mass, which would not typically warrant treatment, but assessment of the risk factors in combination with ADT means that they could or would be valuable to start a bone targeting agent. This is taken from the European Society for Medical Oncology guidelines. I use this as one of my primary tools for decision-making in prostate cancer patients on ADT. So first we get an up-to-date bone density on the patient receiving ADT, and then get a history about the risk factors. So just quickly, on the left-hand side, if we get a T-score less than 2 and they have no risk factors, we know to just optimize lifestyle, basically calcium and vitamin D, and then we'll just monitor their bone density in a year or two. On the right-hand side, if their T-score is less than -2, that qualifies automatically for treatment with a bone targeting agent. Of course, we monitor their bone density over time as well. And then in the center here, it just shows how important these risk factors are, especially for men being treated with ADT. So if they have any two of these risk factors, regardless of their bone density result, we recommend treatment with a bone targeting agent while they're taking ADT. So, in our program, once we've made this decision, we send a letter to their family doctor with recommendations for implementation. So up to this point, I have talked about bone health in prostate cancer patients as it's affected by ADT. The other part of our program is looking at the risk of skeletal-related events. So skeletal-related events is really an umbrella term which refers to pathological fractures, surgery to bone, radiation to bone, and spinal cord compression, which result from bony metastases. So pictured on the left here, is an example of a pathologic fracture from a bone metastases. And so you can see here that there's almost a hole in the upper part of the humerus. Yeah, there you go. And that's led to a fracture. Pathologic fractures can obviously lead to the need for surgery, and pathologic fractures along with radiotherapy for pain are the most common skeletal related events in patients with metastatic prostate cancer. On the right, we see in that vertebral body there, how weakening of the bone in the spine has caused a collapse in that vertebrae, which is now compressing the spinal cord. And as you can imagine, that can lead to significant pain and discomfort, and may require urgent decompressive surgery as well. It's probably pretty evident, but so why is SRE prevention important? We know that the burden of structural damage and bone pain caused by bone mets is quite high. And numerous studies have shown that SREs are associated with detrimental effects on quality of life, mobility, social functioning, and reduced overall survival. So here, I just wanted to mention a study here. In a study of nearly 36,000 breast cancer patients, followed for up to 9 years, the median survival for breast cancer patients with bone mets was 60 months, but was only 7 months for patients with bone mets and a subsequent SRE. So, and we know that in prostate cancer patients with bone mets, there is a very high risk of SREs, and therefore just shows how important it is for us to try to prevent them. As far as candidates for SRE prevention, currently the best evidence is for castrate-resistant prostate cancer patients with at least one confirmed metastasis to the bone. So this is essentially referring to prostate cancer patients that prostate cancer that keeps growing and spreading even after they have had treatment to substantially reduce their testosterone levels. So right now there are 2 recommended therapies for SRE prevention: zoledronic acid by IV infusion every 4 to 12 weeks, and denosumab by subcutaneous injection every 4 weeks. Unfortunately, it isn't as easy as just starting these medications and sending patients on their way. We have a number of limitations here in Alberta with respect to treating patients with these medications. Studies show denosumab is superior to zoledronic acid, but a huge issue is denosumab is not currently covered in Alberta and is quite expensive when administered every 4 weeks. There are also a number of risks or side effects of these medications. So first, a big one is the osteonecrosis of the jaw, which is a condition in which bone cells in the jaw can literally start to die, leading to an exposed jawbone, which can cause pain and can also lead to infection. This is a medical emergency, and so we do our best to mitigate the risk by having patients see a dentist prior to treatment, and always stressing good oral health. Now, we also have to closely monitor kidney function with both of these treatments, as they both can cause further impairment of kidney function in patients who already have moderate to significant impairment may not qualify for the treatment at all. And then another treatment risk is the low calcium levels that can develop with these medications. Sometimes can lead to hospitalizations. Symptoms can range anywhere from like a bit of numbness around the mouth to muscle spasms or seizures. Given all of this, we make sure we monitor kidney function and calcium levels regularly while on SRE prevention therapy. So I know that's a lot of information. Ultimately, bone health and SRE prevention in prostate cancer patients is quite important um, and quite often overlooked, as Lori had brushed upon. Our program is hoping to fill this niche that has been missing for a very long time, I feel. Yeah, and we can just open up to questions if you have any.
Okay, well, I'll start off. This program is such good news. I had my first ADT injection 20 years ago, and I've been on ADT steadily now for 2 years. So fortunately, I was able to get a bone density done 3 years ago, and then I had another one done just recently. I guess my question is radiation in the pelvic area. Would that impact the bone density in the hips, do you think?
I wouldn't say that would be a risk factor for impairing or decreasing bone density. Is that your question?
Yeah. I had my last bone scan indicated bone loss in my hips.
Okay.
Now, I didn't know if that was coincidental to the radiation, or if that was just a result of long-term ADT injections.
Yeah, I think you have it right. As far as the ADT goes, I mean, we just know that the long-term ADT treatment can just continuously decrease bone loss. So I would say that's more likely to be what contributed to the change in bone density rather than radiation, the radiation that you had.
Yeah. Good, because your program intervening sooner rather than later would be such a great thing for many men starting with ADT. So is it mirrored to, or is it part of the ADT seminar that the center puts on now, or are you incorporating some bone health discussions in there?
I can talk on
Yeah,
that one.
that's a good thing for Lori to answer.
So the way that we're trying to assess as many patients as possible is that at the Prostate Cancer Center, any patient that goes into the clinic where they're receiving it for advanced and metastatic prostate cancer, we assess all those patients. So we provide them with a educational package, a requisition to get a bone mineral density test done. They complete a questionnaire so that we can assess their risk factors, and then Dr. Shibata reviews all that material and provides recommendations. So currently, all the patients that go through that clinic get that type of care. We will be expanding in time to take referrals outside of the Prostate Cancer Center, but we're just not there yet. It's taken a lot of time to develop the program, but that's the direction that we're headed. So in time, well, actually, even now, anybody that's initiated on ADT would get all these assessments right off the bat.
Yeah, because there'll be gentlemen that are non-metastatic castrate resistant. And if I understood correctly, you're looking more at metastatic castrate resistant.
Actually, for the program, we're any prostate cancer patient going through the Prostate Cancer Center who is initiated on ADT, whether they're metastatic, non-metastatic, castrate resistant, or castrate sensitive, all get enrolled in the program.
Yeah, that's great, because who knows, had I been able to access this 20 years ago, I may not have the bone loss today, but who knows?
Yeah.
Hindsight's always 2020 when you're driving and looking through the rearview mirror, right?
Yeah. And that is, I mean, that's why Lori and I feel like this is such an important program because, you know, there's so much focus on treating the cancer and making sure there's no spread. And that's obviously very important, but this is sort of this insidious disease that can happen all, you know, parallel to what you're going through. And if we miss it, then you may get complications from that. You know, in addition to what you're going through. So
I don't know if you saw these questions, but Warren at Edmonton had chatted a question here. Is vitamin D the same as vitamin D3?
Okay. Good question, because when we're referring to vitamin D as a supplement, there's different types, but the best one to take is actually D3. That's the one you want to take.
Good. Now he had a follow-up question as well. It's his understanding that statin drugs like Lipitor are primarily calcium. Does this drug add any calcium to the bones?
I would say no. The short answer is no. So basically, if you're calculating how much calcium you are that you have in your diet, or how much you should supplement, I wouldn't consider a statin or anything like that as any additional source of calcium for you.
The floor is open. I just remind everybody to ask your question live. You'll have to unmute yourself. We can't.
How do we sign up for the program?
Okay, so that's a little bit tricky. So I'm assuming, Larry, that you're not a client of the Prostate Cancer Center. Is that correct?
You know, it might sound stupid, but I don't know.
Okay. I don't want to go into details of who your urologist is or anything at this point, but what I would do is speak to your urologist or whoever your primary healthcare giver is for your prostate cancer,
right?
And ask them if you can be referred to the Prostate Cancer Center.
Okay.
Okay.
And what's the name of the program?
We just ask about the bone health. Now, the tricky part right now is that unless you're going to the clinic for advanced and metastatic prostate cancer, you wouldn't be able to get into the program right now.
Okay.
But I think it's worth having the discussion with your primary caregiver for your prostate cancer on just discussing, have you had a bone mineral density test? Can we look at the risk factors and get that discussion happening?
Yeah, I haven't had one. I know that.
Yeah.
Okay.
And that's, I mean, I think that's the most important first step, is just kind of getting that bone density and seeing where you're at right now. And making sure you optimize your calcium and vitamin D while you're on ADT. So
yeah, I think I'm doing that.
Okay, good.
Yeah.
So and then just if your bone density does show some bone loss there, I mean, hopefully your family doctor can make some decisions about about treatment.
Okay.
This is a little bit different. Our thresholds are a bit different than what the typical thresholds are for other family physicians, but it's a really good start to just monitor your bone health. And if you're on ADT for a prolonged amount of time, repeating your bone density 1 to 2 years after too. And if you're seeing some significant decline, that could be a good trigger for your family doctor to start you on something as well.
Okay, thank you.
You're welcome.
I've got a question. Is there a similar facility in Edmonton?
Go ahead.
You know what? I don't know for sure. I know one of my colleagues she does do something similar there. I just don't know how you can be referred to that program. Maybe Lori might know.
Yeah. I know that at the time that I was developing this program, I did consult quite a bit with the Edmonton group, and they were definitely looking into this. So again, I would go back to your urologist oncologist and ask, who could you see in Edmonton to follow up on this?
Okay, I can assure you that I don't know of anybody that's ever had any bone mass density test done. And just for the sake of comment, my oncologist will not even return calls to me. So I've got 3 or 4 messages into this guy, and I'm really at a point I'd like to change oncologists, but I can't even find out how to do that. And at this point, bone density might be an issue because he put me on abiraterone and prednisone. But this is the very first issue that I've ever heard about bone mass density being a concern.
Okay, so to fast track that, you could have your family physician order the test for you.
And I mean, and just as stress with your family physician that you are on prednisone, because that even as in the community, that is definitely something that increases. We know that increases your risk of fracture, and so that may very well be enough to put you on something.
Thank you.
Welcome.
Now, this may seem like a simple question, but if I've had bone density, who would have access to that report? Would the urologist be able to, if it was even done by the family doctor?
Mm-hmm. Yeah, the tricky part, and this is the whole reason that I developed this program, because the urologists and oncologists are very, very busy when they see you, and they're dealing primarily with your prostate cancer treatment. And it's incredibly challenging to take on the responsibility of, they may order a bone mineral density, but then if it comes back as osteoporosis or low bone mass or whatever the case may be, to follow up on that treatment, sometimes that gets lost in the shuffle. So yeah, I probably would suggest your family physician looking
But
up
they
that.
would all have access to it, so it didn't matter who ordered it.
Yeah,
Family doctor.
They technically should, because the NetCare, the provincial sort of central database, technically they should have access to it. But again, the complicating factor here is just that the guidelines are different for prostate cancer patients versus non-prostate cancer patients. So it's hard to interpret, I think, sometimes if you haven't looked into all the literature and learned about what increases risk and that sort of thing.
Mm-hmm.
I guess in my own experience, my family doctor took an immediate interest in bone health.
Good.
When I was first diagnosed through his clinic and then into the rapid access at the old prostate cancer center. And also Dr. Ruther, as a medical oncologist, did have me on Zometa about, I think, once a 6-month injection over at the Women's Center for probably 6 years or so. So there certainly is an awareness.
Yeah, that's good.
But, I've not had any discussion with my med oncologist since I began to take a number of the androgen receptor type drugs. The one mention was made of the abiraterone, and you do need to take prednisone there, but no follow-up as to what the bone density evaluation might look like. I was already at risk. So perhaps that's how it sort of falls off the track, is that you know that you're at risk, and the primary treatment is indeed the cancer treatment. And I've been 5 years on various types of taxanes, and again I'm taking prednisone in those situations, but no discussion about whether we should go and have a look at the bone density. And perhaps there's not much one can do at these later stages. I really don't know. So far, your emphasis has been on AGT, and I can appreciate that. But we do have a lot of men that are taking prednisone for a long time, have been taking ADT for a long time. And after the initial flurry of interest in bone health, and particularly bone density, it all sort of fades. At least that's my experience.
Yeah, I mean, it's, I mean, I don't know your all of your background in medical history, but so because you said you had Zometa for 5 or 6 years.
Yep.
So, I mean, it's definitely, if you're going on prednisone, something to discuss with your family doctor again and see if you'd qualify. But part of the issue is also that there's some studies showing that if you've been on a bisphosphonate for a long period of time, you know, as you kind of alluded to a little bit, it's questionable what effect it can have, and longer than, say, depending on the patient, 5 to 10 years, right? So, I mean, I still think it's a worthwhile discussion to have, but I agree with you. Part of I think our first barrier is just awareness across the board with healthcare providers, but secondly, it's making sure people continue to address bone health moving forward, you know, and not forget about it.
What comes to my mind is that Prostate Cancer Center really only begins to come up in a man's thinking and horizon when he has indeed been diagnosed with prostate cancer. And yet some of the numbers that you were suggesting indicate that the fellows coming in the door prior to being diagnosed have that their awareness of the importance of bone density is quite low. Mm-hmm. And that the family physician hasn't maybe been spending enough time on the importance of bone density, irrespective of whether there's a cancer diagnosis or not.
Mm-hmm.
Yeah,
I would agree with that. On the Osteoporosis Canada website, they list the percentage of men that actually have a bone mineral density test done, and it's quite shockingly low. So it seems like, you know, the thinking is that osteoporosis is more of a female disease, but it's not. And you're absolutely right. I think it needs to be a bigger focus at the GP level.
Mm-hmm. Yeah, agreed.
Now I'm going to put you on. Oh, I'm sorry. Go ahead.
We wouldn't be approaching this topic with anybody just coming into the Prostate Cancer Center unless they were at an advanced stage and on hormone deprivation therapy. That's our target population. So, yeah, definitely. Because as I talked about earlier, there's certain criteria that you should have a bone mineral density test done if you've had a fragility fracture. You know, there's a number of reasons why you should before age 65, but it often doesn't happen.
I can only agree with what you're saying there, ladies. And I had a small fracture on my number 5 metatarsal bone in my foot through a rather freaky fall. And my doctors knew all about it. And they didn't even make the slightest indication of a bone mineral test. The bone took like 14 or 16 weeks to kind of heal up. And it never did leave a major lump in my bone or otherwise. But, it might be a thought to tell some of these oncologists about bone mineral tests, because truthfully, either they don't know or they simply don't care when they make these drug prescriptions whether you should be doing anything else to guard your health. They're only interested in what the PSA number says, period. That's it. And there's really nothing they care about that can lead to any other side effects. And I guess just to add to that, I've had heart attacks. I've had all kinds of other issues from these doggone ADT drugs they get, and they don't even identify those problems to the patient, even though it's well on the website that these things can actually happen. But even then, the doctors were surprised to find out that it can cause heart troubles. So it's a big disappointment when you go to the hospital and you know more than the doctor does.
Now, I'm going to put you on the spot, ladies. If you had to pick one resource that you would recommend for our members to learn more about bone health, where would you send us?
I personally would send you to the Osteoporosis Canada website. It's really, really good.
Yeah, I second that. There's so much information on there. And they've even tried to put videos up to kind of explain things as well. So I think it's a really good resource.
Mm-hmm.
Yeah, because obviously we have a lot to learn about bone health, and we've got a great opportunity here. So I want to thank you for making time for us this evening and sharing your experience and your knowledge. And I think the program is a big boost to the ongoing quest to improve men's health. So thank you for the work that you're doing. We appreciate that.
Thank you.
Thanks, Fred.
Thanks for having us.